Hello, ladies and gentlemen. Welcome to Triple N Media. In this presentation, we are going to look at pacemaker-related electrocardiograms. How do we identify what kind of pacemaker this patient has? Is the pacemaker working? And what type of device is in the patient? And how to interrogate the pacemaker based on the surface electrocardiogram. So let us begin with the feature presentation. Here's an X-ray of a patient with a pacemaker leads and a battery, and here is like a character representation of the pacemaker leads. And we are going to start off with the different types of pacemakers that are used in patients with various cardiovascular conditions, either be related to bradycardia, heart failure, or cardiomyopathy, and see how we can identify them on the surface electrocardiogram. Basically, we have a single chamber pacemaker, in which case a wire is placed in the right ventricular apex. It is known as VVI, that's ventricular activated, ventricular inhibited pacemaker. And a dual chamber pacemaker is where we have a lead in the right atrial appendage along with a wire in the right ventricular apex. We see in patients who have what is known as biventricular pacemaker, along with maybe they could even have ICD, which is intracardiac defibrillator. In a patient with like biventricular pacemaker, in addition to having an atrial wire, we also have a ventricular wire, and there is also a wire going through the coronary sinus into the posterior cardiac vein or the lateral cardiac vein that activates the left ventricle, and that's why it is called biventricular pacemaker or cardiac resynchronization therapy, or CRT as it is abbreviated. Here's a chest X-ray showing the placement of the leads. Here we have the right atrial appendage where the right atrial lead is placed. Then we have the ventricular lead which is placed here. Then here's a wire, very tiny wire going into the coronary sinus into the cardiac vein, most likely the posterior cardiac or the lateral cardiac vein, which activates the left ventricle, as I said. So based on electrocardiogram, we will be able to identify as what kind of pacemaker this patient most likely has in many cases. So let us start off with the first electrocardiogram. Here's the first electrocardiogram. Here we see a pacemaker spike and a wide QRS complex, most of which are in the negative direction, suggesting this is ventricular pacing. In addition to that, we also see some P waves here, and the question is this atrial sensing and ventricular pacing? If that is the case, we need to see a constant PR interval. Here it looks okay, here it looks okay, but here's a P wave which is not looking the same as the other one. So there is an underlying atrial rhythm. There is an underlying atrial rhythm which may be severe bradycardia, and this P wave is of a different morphology, so it could be an ectopic beat, and that's something we need to be concerned about. So basically, we have a very slow atrial rhythm in the upper chambers. We have a ventricular pacing, which is most likely a single chamber pacing based on this electrocardiogram. So let's look at the next electrocardiogram here. First of all, we have a narrow QRS complex. And if you are just glancing at it, you may think this is a normal sinus rhythm. However, if you look at just before the P waves, there's a little electrical notch here, and that is consistently seen in every beat. That suggests that this is atrial pacing and ventricular sensing. What does that mean? This is a dual chamber pacemaker, atrial and ventricular, and it doesn't see an atrial impulse coming, so it paces the atria and then it waits for the ventricles to activate, and if the ventricles activate, then the ventricular pacemaker is suppressed. So we have a narrow QRS complex, which is different from the previous one we saw. When the ventricle is activated, we see like a wide QRS complex, like a bundle branch block. So whenever you see a narrow QRS complex after an atrial pacing, that means the impulse was conducted through the normal AV conduction system. So we have a atrial pacing, ventricular sensing rhythm. Most likely it is a disease of the sinus node because the atria had to be paced because the expected impulse was not coming at the right time. Let's look at another electrocardiogram here. Again, we have a atrial spike here. So first of all, let's mark this atrial spike and see if we have a consistent PR interval. We do have a consistent PR interval. So we have a atrial pacing, ventricular sensing because we don't see any ventricular spikes. And in addition to that, we have a right bundle branch block. So this is not a ventricular pacing. This is not a wide QRS rhythm. It is basically atrial pacing with the right bundle branch block. And that's what we see on this electrocardiogram. Do you see anything else in this electrocardiogram? Okay, let's move on to the next one here. Again, we have an atrial spike here, and there's an atrial wave which looks like biphasic here, and it is consistently seen in all the leads. So we have atrial pacing, narrow QRS complex, that is ventricular atrial pacing and ventricular sensing, and a narrow QRS complex. The SCT changes look okay, so that's fine. Let's move on to the next electrocardiogram here. We have a atrial sensing here. We don't have any atrial activity, and here I see an atrial activity here, and the atria is activated. The second time the atria beat comes earlier, so this could be a premature atrial beat, because if it was a regular beat, it probably would not have come on time and we'd have seen an atrial activation. So this is the atrial pacing and ventricular pacing also, and it could be a sort of a fusion beat because the QRS complex is fairly narrow for ventricular pacing. But nonetheless, the next beat seems to come early, and this could be a premature atrial beat, and that is followed by ventricular pacing. And here we have a QRS morphology which is different. We see an atrial pacing and a long interval here. It is not clear if the atrial, this is a change in leads. So we don't see an atrial pacing here. All we see is a ventricular pacing, and the QRS is wide, or maybe it is an extra beat because we had a normal beat, a premature beat, a pause, followed by a PVC. I mean, that's how you have to deduct, because there's grouping of the beats here, like 2 beats, pause, wide QRS, 2 beats, pause, wide QRS. So this is atrial bigeminy with the escape ventricular beats. That's my interpretation. All right, here's an example of atrial pacing with a wide QRS tachycardia, and there's also ventricular pacing. If you see it, and here it's pretty clear, we can see that. So we have atrial pacing and ventricular pacing, and all these deflections are negative, with the exception of one and AVL, which suggests the impulse is going from the right side of the chest to the left side, and you wonder if this is like a cardiac resynchronization pacemaker. But in cardiac resynchronization pacemaker, we should be seeing positive deflections in V1 and V2. So this is just atrial pacing and ventricular pacing, and the rate seems to be reasonable, so the pacemaker is working adequately based on the surface electrocardiogram. Here we have another example of atrial pacing, ventricular pacing with wide QRS tachycardia, and we have negative deflection. I think it's similar to the patient we had before with some positive deflection in 1 and AVL and also AVR. But the chest leads are all showing the impulse is going from the apex of the heart towards the, and here we have another atrial pacing, ventricular pacing, and same thing, atrial pacing, ventricular pacing, and with negative deflection here suggestive of dual chamber pacemaker. A spike here followed by a wide QRS tachycardia. And if you look at it here, the previous slides, we had this one. We should have had this image also. So now, if you look at the deflections here, these are all negative. But if you look at the deflections here in V1 and V2, they are positive. That suggests the impulse is, that suggests that we have ventricular pacing and atrial sensing. So in conclusion, ladies and gentlemen, just based on the surface electrocardiogram, we will be able to identify atrial pacing, atrial sensing, ventricular pacing, ventricular sensing. We can also identify the presence of chronic resynchronization therapy if you see a positive deflection in V1 and V2, and we can look at the rates, we can look at the capture, and we can look at the activation of the ventricles of the atria by the pacemaker spikes, and based on that we can see whether the pacemaker is adequately working and what type of pacemaker we are dealing with. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next presentation with more complex electrocardiogram.